So morning.
So we have our speakers all the way down.
No. We're gonna do it. I'll do it. Now, after the dean. No, after the dean speaks. Malik is. Yeah. Yeah. Yeah, we're gonna just do some quick reviews right now. Introduce the dean on stage. He's gonna do his thing. I'll come back up to give an overview. And to give out the presentation. So if you can help me with give out the details. Help me with that.
Yes, exactly. Give us marching orders.
Yeah. Could someone grab Vanessa? We're gonna get started. Oh, there she is. Right. Vanessa? Okay, good morning. Welcome, everybody. You can take a seat. If you haven't already, please sign in. There's a QR code on the screen that you can grab. We want to make sure that we have an accurate attendance for the day. My name is Efikona Nuer. I'm the chair of the Occupational Therapy Program, and I want to introduce to you a fearless group who has really been instrumental in putting this day together. I'll let them introduce themselves.
Hi, I'm Dave Kaufman from Informatics. This is a really special day. First, we have some empty seats, so please call your friends, tell your friends to call their friends, and let's fill up this place. I'm hoping you can stay for the day. There's some great presentations. So this is a mix of an academic and social event. It's really the only time of year where we get to sort of intermingle and see each other's research. And we look forward to that. I look forward to viewing a range of posters and participating in that. So thank you all for coming, and hope you have a great day.
Good morning, everyone. My name is Yasser Salim. I'm the chair of the Physical Therapy Program. I'm a member of the School of Health Profession Research Day. This is a day that you should celebrate, especially people who have their poster. This is a nice achievement, something that you will add to your resume and your CV as you go in and hunting for a job. So congratulations to you, and for the students who are not presenting to you, this should be an inspiring moment for you so you can prepare your poster for next year. Thank you very much, everyone, for attending, and congratulations.
Lower this a little bit. Hi, everyone. I'm Dr. Valles-Lewis, Vanessa Valles-Lewis. I'm the Assistant Dean for the School of Health Professions. Thank you to all who came down already from the nosebleeds, but I'm going to invite everybody else to continue to come down, because you know I like my Instagram photos, right? I want them to be perfect. So please come on, join us. We don't bite. The front row is empty. Okay. Congratulations to everyone who's here, who's made it to SOHP Research Day. This is a great professional development opportunity for all of you. For those of you who are presenting, like everyone said, this is a great resume builder. This is also an opportunity to spread your wings and to, engage in public speaking and to interact with your peers. And in terms of, really, shining the light on all of your unique research experiences, this is a great opportunity to network and to continue to, as you move on, expand on your research topics. So don't let this be the end. This is just the beginning for your research. And congratulations again. And I'll be behind you taking photos.
Thank you. Thank you to the committee for all the work you've done to get us to this day. Thanks to everyone else, media services, catering services, the Dean's Office for supporting us so that we can showcase all the great work, the scholarship and research from both students and faculty in the School of Health Professions. Today, we will continue with a word from Dean Lewis. After that, I will be back on stage to do a quick overview of the research capacity of the School of Health Professions, and then we'll get into the student presentations. We have a group from the programs within SOHP, an exemplary group that kind of demonstrates excellence in scholarship in their projects that they did this year. So I'm looking forward to hearing from each of those groups. And then we should break around 12:30 for some light refreshments and a poster viewing. And like the others have said, that's a real opportunity for you to engage and connect with each other on one of the few opportunities we have like that as an entire school. So, walk around, ask questions, be curious. That's what really the day is about today. That's all. I'll be around to help anyone if you need anything. But without further ado, I would like to bring to the stage Dr. Alan Lewis.
Good morning, and welcome to our 4th year of Annual Research Day in the School of Health Professions. I'm Alan Lewis, the Dean. I was checking with Dr. Newell to make sure this was year 4. Somehow I thought it was 3, but you know how time gets away. Good to see so many of you today. So I'm going to say a few things about research. I'll be brief, and then we'll get started to kind of kick things off. So, research in terms of its etiology, its origin, its start, it really comes to us from philosophy, the branch of philosophy known as metaphysics, which really deals with those first principles of the universe, things like being, time, space, those existential concepts that we always want to try to figure out, right? Of course, we know that religion gives us some explanation for those things, but in a secular kind of way, metaphysics is where we kind of hear about that a lot, and that's sort of where research gets its beginning. And within metaphysics, there's something called ontology, which is the nature of existing and being. These are sort of the original research questions that existed. You guys are way farther downstream now, but in the beginning, these were sort of the first questions. This is how it all got started. And then, of course, research really serves in several purposes for us. One, epistemology, which is sort of the nature of knowing and the scope of that knowing. And it gives us a way to do disciplined inquiry. That's how we begin to understand research, that we have to be systematic, structured, and use critical thinking to answer questions, right? Disciplined inquiry, AKA research. But going back to philosophy, we also know that philosophy of science tells us some things about research which give us sort of the foundation of our methodologies, quantitative, qualitative, mixed methods. So there are 2 schools of thoughts that really give us the quantitative underpinnings. Positivists and post-positivists tell us that research really has to be conducted objectively. It needs to involve causal thinking, cause-effect thinking. It needs to be experimental. It needs to be comparative. And you can automatically see that as the basis for quantitative methodology, right? But then there's another school of thought called the constructivist school of thought that says, research can also be subjective. And in that subjectivity, we have the basis for qualitative research. And then there's a transformative tradition in the philosophy of science, which really speaks to the idea that, research can also include things like history, culture, social concepts. And that gives us sort of that understanding of the lived experience, which really does give us a grounding of both mixed methods and qualitative research. So we know that research serves many purposes. It comes out of philosophy. But the main thing about research is that it serves many roles for you as healthcare providers in the making, because very soon you'll be out in the real world. And what we want you to know is that research is going to really be something that's going to help you. It's going to help you, first of all, its first role for you will be, and all of us, is to advance knowledge. So in any field where there's no knowledge, research is how we begin to develop that knowledge, that beginning base of knowledge about what we understand about the phenomenon in a particular field. And then as we begin to have that beginning base of knowledge, over time we advance it. through more research. So it's like building a fence. You know, each link connects to the previous one, and after a while, we have a pretty big fence, right? Pretty big base of knowledge in a given area. So it will be a way for you to really understand how to develop new knowledge and advance current knowledge. Also, most of you will be clinicians, practitioners, providers. You'll have questions that when you practice clinically about, I wonder why this happens all the time when I see this kind of patient. It gives you the tools you need to answer those questions if you're so inclined to want to answer them. In other words, embark on the research process. It also gives us, next role, third role, sort of the bounds of our evidence-based practice. All of us want to practice using tools that we know have been tested and proven to be effective. They're efficacious first, meaning they're effective under lab control conditions, and then they become effective, meaning they work in the real world, produce desirable benefits on the persons we're providing services to. We want to understand that the tools we're using, the strategies, the modalities that you're using every day as clinicians in your respective disciplines, are things that have been based on evidence that says they work, they actually help people. Otherwise, what are we doing if we're using tools that we made up ourselves, that haven't been researched and validated as being effective? So it gives you a way to actually understand what the evidence is, to support your delivery of methodology that you're using as a clinician. It also gives you a way to be involved in advancing that evidence if you're so inclined, if you want to do some research yourself. And the final role of research is really to understand how effective you are. You know, we now live in a world that is really driven by accountability. And I think that many of you are going to be in situations where you're going to be drawing a certain salary per year, and they're going to say, well, can you show us some data that speaks to why we should continue paying you this salary? What's your effectiveness in terms of helping the patients, clients, service recipients, the customers that you're providing services to? How do you do that? Can you show us in a way that's not anecdotal, that's data-driven? So research gives you the tool to evaluate your effectiveness, to assess your effectiveness. Because the questions you always want to answer as a clinician is, first of all, why are we doing this? Is there really a need for the service that you're providing? That's a needs assessment. That's a research process. And then you want to ask the question of who? Who are we serving? Are you really serving the people who can benefit from your services? Because we all know that every service delivery system or program has a certain criteria of who the target population should be and who can benefit from the service. That's also a research process. It's more descriptive, but it's a research process, understanding the who that you're providing services to. And then there's the what. What's the service you're providing? Is it evidence-based? Is it based on theory of change? Do you have any reason to think that it's going to result in a positive impact when you deliver that service? That's also a research process because it's based on the evidence-based practice. That's the what. And then it's how much. That question is a dose question. You could have the best intervention in the world based on all the evidence. Randomized controlled trials, systematic reviews, meta-analyses, all the rigorous quantitative approaches. But if you're only giving 50% of the dose, is it really going to help the person? That's the how much question. And then, how effective? How effective are you? Are you really seeing the desired benefit in the people you're providing services to? That's a question you got to answer as clinicians. And then if you can answer that question in the affirmative and say, yes, we're providing a good service, people are getting better, then the question is, can you afford it? How much? Because, you know, if we had $1 million to devote to each person you're providing services to, I'm pretty sure we could promote some positive outcomes. But do we have that much money? Absolutely not. So that's the cost-benefit question. How much does this cost to produce that outcome? Those are the questions you're going to have to ask yourself, you should ask yourself going forward, using research tools to answer them about your effectiveness as a clinician. So the bottom line message, take-home message today from me is that research is something that you should have a close affiliation with, not just now that you're in school, but as your career goes forward, because you know it's going to be your best friend. It's going to help you in so many ways. It's going to help you figure out how to advance knowledge, understand the bounds of evidence-based practice, answer those curious clinical questions, and evaluate your success. So with that, don't shy away from research. Embrace it. Hopefully we'll have a great day today. You got a lot of good examples of research that you're going to see. So let's get going and let's take advantage of it. And let's use research, embrace it as we go forward. Thank you.
Okay. This morning there was a lot of energy and excitement out in the hall, and I want to keep that going. Just to remind you, we are also live streaming, so I want the people at home viewing us to feel that energy. And right now, they are seeing some empty seats in the front. So if you can, like Dr. Valdes-Lewis said, move up a little bit. Let's make sure that we can fill these seats up here so that we can project that same type of energy that's happening in this room. Okay. Okay, so before we move on, good? Testing? Okay. Before we move on to the student presentations, I just want to take a moment to have a look back at the academic year and celebrate the research and scholarly engagement from the various SOHP programs. So here, under the leadership of Dean Lewis and the dedication of the faculty, our SOHP programs and the research capacity within them are growing. In this academic year, we saw over 20 conference appearances by faculty, 15 major publications, and a diverse range of book chapters and non-traditional scholarship from the faculty. And this is just a peek at how the research engagement in the school is increasing across every single program. Beginning with applied behavioral analysis, our ABA program, huge congratulations are in order. The ABA program is officially ranked first nationally in peer faculty research productivity, and this is really a massive achievement that's recognized by one of the practice journals, Behavior Analysis and Practice. Then there's diagnostic medical sonography. In sonography, the program is evolving to meet the world's needs. This fall, DMS will be launching a new certificate program to expand access to vital training. But they aren't just teaching, they're trailblazing. And we're thrilled to share that Professor Yan Lee will be presenting on behalf of the program at the 2026 AIUM Annual Convention. So let's give sonography and Professor Lee a round of applause. Then it's health informatics. Health informatics this year, the program has pushed the envelope in precision care and digital health, from research looking at COVID-19 reporting burdens to human factors and organizational studies. Our informatics faculty and students, they're ensuring that the future of healthcare is data-driven and patient-centered. So just a round of applause to the health informatics program. Our midwifery faculty who are here in our program, they continue to be champions for maternal health and equity. This year's scholarship is focused on the why and how of care, from foundational prenatal education to critical research on supporting midwifery students of color, with Dr. Susan Rachel Condon leading the national panels on bias awareness education. This program is literally shaping the future of birth equity. So thank you. My home program, occupational therapy, we're leading the way in inclusive education and practice. This year, our occupational therapy faculty have secured prestigious honors. Myself as a SUNY Accessibility Fellow, Dr. Vikram Pekpatan as an AI for Public Good Fellow, as well as Dr. Jasmine Thomas, who received very recently a research award, the Virginia Radley Fellowship for her proposed work on the historic Black nurses of Seaview Hospital. And then add in Dr. Suzanne Rappaport and her vital work in gender-affirming care. I think it's very clear that the OT program is a powerhouse for advocacy. Then we also have physical therapy. Physical therapy is driving the science of movement. Under the leadership of our new chair, Dr. Yasser Salem, the program is tackling everything from cerebral palsy and Parkinson's to aquatic therapy and neurodynamic mobilization. Their massive presence at the APTA conference recently ensures that the work being done here downstate is being translated widely in clinical practice. So shout out to the PT program. Yeah. So, just looking big picture, the SOHP research footprint is accelerating. We have more faculty participating in research than ever before, which really creates a vibrant ecosystem for students. And that's really what we're here for today. As you will hear from the student projects that are coming up, these are faculty-mentored opportunities where students have the opportunity to engage in community advocacy and direct translation of knowledge to improve patient care. So as we move through today's sessions, just remember that your work influences clinical practice, informs our curriculum, and advances the health of our entire community. So thank you to each of you for your dedication to excellence, and let's have a really incredible research day. So thank you. All right, so first to the stage, I would like to call the group from PA, from Physician Assistants. I'm sorry? Oh. Sorry, I missed something.
Just wait, so how do I go next?
How to change?
Like a keyboard?
Yeah.
Okay. Okay. Gotcha. All right. Hello, everyone. My name is Josh. This is Shavar, Damien, Mike, and Eugene. And today we'll be discussing using AI to prevent and manage CKM syndrome through personalized life support and community resource navigation. And we'll be focusing on Flatlands and Canarsie. Cool. All right, so first, what is CKM? CKM stands for cardiovascular kidney metabolic syndrome, and in simple terms, this means that the heart, kidneys, and metabolism are all connected. CKM includes conditions like obesity, insulin resistance, high blood pressure, and abnormal cholesterol levels. These conditions can lead to serious health problems like heart disease, type 2 diabetes, stroke, and kidney disease. CKM is divided into stages, stage 0 being no risk factors present, stage 1, early risk factors are present, and stage 2, someone already has morbidities like hypertension, diabetes, or kidney disease, and stage 3, cardiovascular disease may be developing, and stage 4, cardiovascular disease is present, such as cardiac arrest, stroke, or heart failure. So CKM helps us understand how early risk factors can accumulate over time and increase mortality. Okay, so who is most affected? A higher burden is seen in African American and Hispanic populations and lower socioeconomic groups. Looking at this graph, focus on the red, which represents Flatlands and Canarsie, and in comparison to other parts of Brooklyn represented in yellow, Canarsie and Flatlands surpassed them in obesity, diabetes, and hypertension. For hypertension, the community rate is higher than Brooklyn, but lower than the national average shown on the graph. Even though it is lower than the national average, it is still a concern because hypertension affects large portions of adults in this community. Factors like income, healthcare access, environment, chronic stress, and dietary patterns can make it more difficult for people to prevent or manage these conditions.
So these are the major points we will address in our presentation and our tool that we want to implement, beginning with how local food environments shape dietary behavior, the role of cultural dietary practices versus modifiable risk factors, healthcare access gaps and their impact on CKM outcomes, why socioeconomic status alone does not explain disease burden, how AI can deliver culturally tailored patient-specific education, and strategies to improve health literacy without undermining cultural identity, and lastly, methods to ensure equitable, bias-aware AI implementation. To understand the true health landscape of Flatlands and Canarsie community, our study approach uses multifactorial analysis to examine social determinants that shape the daily lives of almost 200,000 residents in this part of Brooklyn. The primary demographic makeup is around 57% African Americans, 21% Caucasians, 8% Hispanics, and 5% Asian. We will also observe the education level, food access, crime stress rates of the neighborhoods, along with healthcare access and income. Based on our research, there appears to be a socioeconomic contradiction in our neighborhood of interest. Although we have a 15% higher median income average within this district at around $90,000 per individual annually, the prevalence of CKM diseases are disproportionately elevated compared to the traditional low-income risk factor, leading us to a statement that high disease burden does not match expected socioeconomic trends.
Hi everyone, I'm Damien. So as we can see that it's not driven by poverty alone, right? And so other contributing factors are the food environment, the access distribution, lifestyle, and acculturation. So acculturation is when a culture has their own food and they prepare it the way they normally do, but then you add on the American diet to it and then it drives up CKM. Right, and so we can also see there are other barriers that are involved. The geospatial analysis shows that even though this area is not considered by federal standards a food desert, the supermarket to bodega ratio is about 1 to 9. So every one supermarket, there's 9 bodegas in the area. So what does that mean? Bodegas normally carry more processed foods, higher sodium foods, and sugary beverages, right? So if you're hungry and you want something to eat, you're gonna go for what's more easily accessible, and that's gonna help you to make a very poor food choice, and all those things will drive up CKM, right? And so in addition to that, there's also some healthcare access issues. So in the areas of Flatlands and Canarsie, there's approximately 55 to 65 primary care providers, and they're serving 193,000 people. So if we do the math, the ratio comes out to be 1 to 3,500. And so the federal average to be considered a poorly served area has to be over 3,500. And so we're right on the precipice of that. And if nothing changes soon, we're really going to hit that mark. And so it results in a poor spatial distribution, reduced walkability, right, and unequal access based on how healthcare providers are spaced out.
So, as you probably have noticed, we discovered that diet plays one of the significant roles in the CKM syndrome development. So we decided to look a little bit further and look at the cultural, ethnic background of those diets. The interesting findings they found was that the traditional diets themselves do not inherently are unhealthy. However, such risk factors as how food is prepared, for example, frying, the food that have added excess of sodium, excess of the glucose, sugar, or the portion size itself will determine how food is healthy or not. That being said, we realized that there should be more advisement and education be in place for the patients to be aware how to cook properly and healthily, how to control the portion size, or even modify the portions. That being said, yes, okay. That being said, we discovered that the acculturation phenomenon plays one of the significant roles in how diet become non-healthy, meaning that when there's just inherently traditional foods in the families, it's not that dangerous. But when you mix extra calories for the mainstream food, especially, as my just colleague mentioned, from bodegas, that really significantly changes the food outlook. So what we are proposing is using new technology of AI to have an app of a two-pronged approach. The first side of the app will deal with including people who are in a high-risk population of developing CKM syndrome, and it will allow them to be aware and to reduce those risks. The second side of the app will help the already patients who have CKM syndrome and healthcare providers to work easier together and to manage it better. In more detail, we envision to use AI chat features for the first side of the app for incidence reduction, provide education, suggest diet changes, offer culturally tailored advice, and connect users with the healthcare providers, such as dietitians. So they are not just become aware of the dangers, but at the same time, they have a choice of how to change the behavior and how to be practical about implementation of new diets. The people who already have the CKM syndrome, we provide an AI bot feature, which would allow the communication between healthcare provider and the patient. We believe that it would allow the patients to have more engagement, an opportunity to be reminded of the behavioral change that they would agree upon with the healthcare provider. And for healthcare provider, this app feature would allow them to easily see how the patient follow up and to screen the patients. Interestingly, we also believe that this app would increase the cultural responsiveness for the patient population and decrease stereotyping. It makes it more easier to have an individually tailored habits suggestion. It makes it more easier to have a culturally appropriate language implementation. Also, it will be cheaper to access. Will also be universal because we believe that the app will be available on the phones and the computers, and as long as everybody has internet, they can access it 24/7. Now I would like to, Shavar.
Okay, so I don't even know what, good morning. All right, so we have identified specific AI challenges that we would need to address. The first issue is lack of awareness. So we understand that not everyone knows about all the applications of AI, especially the use as a public health tool. So our goal here, which starts today in this presentation, is to educate people on AI potential and also to look for partnerships. The next issue is trust. Yeah, we understand that AI currently is recognized as a public tool with general information that's not always verified. So our goal with our app is to ensure that it's trained in a cultural appropriate and responsive manner, avoiding bias and stereotyping. And we will also ensure that the AI tool is trained on clinically approved evidence-based sources, are trained from clinically approved evidence-based sources. For the third issue, we know that technology access is an issue, because not everyone has a phone, right? So our goal is to partner with government agencies and insurance programs who have the capability of providing devices to those who need it so that they can have access to our AI tool. And the last is digital literacy. We understand that even though the tool is in their hand, then some people might still not understand the benefits and how to use it appropriately for their preferences. So we'll ensure in our implementation process to provide brochures to show users how the app will work and to have sample questions based on their personalized preferences. And now I'll let my friend here, Mike, tell you about how we plan to evaluate the effectiveness of the app. Oh, sorry, sorry. Anyway, sorry, I forgot to mention one thing. In the community of Flatlands, how we plan to get the app launched in that area, we would communicate with local healthcare providers, community leaders, churches, food programs, and school programs. And yes, so churches, schools, and food programs using flyers and QR codes or any other means of communication. Thank you.
So evaluation metrics, how do we know if our app is actually working? These are what we want to use to screening rates, physical activity, and new CKM cases. And we're going to also do some lab values to measure if our patients are actually improving. What we're really trying to capture here is not just whether our intervention works, but how it impacts people with at different stages of the disease. On the prevention side, we're looking at incidence. Are more people getting screened, asking questions, engaging with their health earlier? That tells us we're shifting behavior before the disease fully develops. On the management side, prevalence helps us understand real clinical change. Are patients actually improving? Are we seeing better blood pressure control, lower A1C scores, and overall healthier outcomes? That's where the intervention becomes meaningful in the clinical sense. But numbers alone are not enough. We also need to understand the patient experience. Through in-app feedback, we evaluate whether the tool is easy to use, culturally appropriate, and most importantly, trusted. Finally, the integration with providers ensures that this isn't just a standalone app, but a tool that strengthens the connection between patients and their healthcare teams.
Okay, so in conclusion, right, we looked at CKM syndrome in Flatlands and Canarsie community, and we found that the food that the residents have access to, as well as the food preparation practices, has greatly influenced the rate within this community. Therefore, we will try to tackle the incidence and prevalence rate through our implementation of our AI tool to modify behavior, to educate, increase access, and improve the care coordination between healthcare providers and their patients. Thank you for listening.
All right, everybody. Take out your phones, scan the QR code. AI is the tech of tomorrow. Let's use it to make a better tomorrow. The name of our app is CKM. Check your health, know your health, manage, stay ahead, take advantage. Thank you. Questions?
Thank you. Thank you.
Okay, we have a question from the audience.
Okay, so do you guys have like specific features that would help to maybe reduce food acculturation? Oh, I said, do you guys have features that might help to reduce food acculturation and like help people to choose foods that are healthy, also in line with their culture, and maybe not choose something that's like so less healthy?
All right, so one of the features we want to implement in the app is pretty much for the app, when the patient would ask the app or the AI tool, hey, what can I do to improve my disease? And through the training of the AI interface, it would tell them about acculturation and the way that they're preparing their food, and it should be linked to their patient profile so that when they see the patient sees their medical history, the app should incorporate that, what their medical history is and what the type of food they should be eating.
Yeah, to add on to that, it would incorporate their cultural, like making substitutions to their current meals to improve and prevent acculturalization, or help them create like a dietary plan that could include foods outside of their culture that they want to include in their daily lives that should help them reach their health goals.
Yeah, so essentially we envision a situation where the app would advise them, hey, you see, if you add this, how much calories, how much this whole sugars and lipids increase in your food. So they know they see by real examples they can put in the food, and they can see how much it changes their food plate, essentially.
Actually, I have a comment. First, great presentation, great looking slides, really important topic, very impressive. There's a couple ways of thinking about AI app. So one of the things you want to do is get beyond a conventional view of an app. And for example, an agent, something that lives with you, something that you could take a photo, it keeps track. It's like continuously available to you the way Siri would be and so forth. It'll provide you some guidance throughout your day. Like not based on your profile or anything, it's just sort of living in the moment with you. And that technology is realizable. The other comment is that I think it's very important to evaluate the app, but I think looking at issues of prevalence and other community factors is kind of beyond the scope. Overall, great work. Thank you. Well done, guys. Thank you.
Okay, wonderful, wonderful. Thank you, PA program, for getting us to a fabulous start. Next onto the stage is the group from physical therapy. Welcome.
Good morning, everybody. My name is Luis Dominguez. We have Tyler Diamond, Vikram Kuner, Jesse Liu, and Toyin Joseph. Today, we will be presenting our New York State pilot survey on how entry-level Doctor of Physical Therapy programs prepare graduates for COVID-19 and post-acute sequelae of COVID-19. The work was conducted under the mentorship of Puneet Dhaliwal. She's right there. I want to give my flowers while I'm up here. All right, so let's give a little bit of background and historical context on the topic. The coronavirus family has been recognized since 1968, named for the solar corona appearance under electron microscopy. What is new with the SARS-CoV-2 virus is the magnitude of the chronic rehab burden it has produced. So as you can see in the picture, the color red is it stands out. The color choice in the pandemic communication was deliberate. Red was used to encode urgency and signal social distances imperatives. This visual framing shaped public expectations of clinical response, which now extends into the rehab setting itself.
I'm going to talk a little bit more about the background. So globally, cumulative cases exceed over 779 million as reported by the World Health Organization. 6 in 100 of those cases who have COVID will eventually get long COVID with over 200 unique symptoms reported. The average recovery can be anywhere from 4 to 9 months, and this can vary depending on higher risk factors like women, older adults, and those with more chronic conditions. It's also important to know the economic cost that this may have. The Organization for Economic Cooperation and Development predicts that long COVID will account for 0.14% of total health expenditure over the next decade. And labor force reductions in 2021 show substantial results that Eastern and Central European countries dropped for substantial levels. This economic argument presented here further enhances our rehabilitation argument and shows why it's important to include this in our curriculum. What do we know and what do we not know? So there are rehabilitation guidelines out there for long COVID, but there's no empirical data to show how these DPT programs are implementing it in their curriculum. Our study looks to address 3 of the concrete gaps: content, instructional strategy, and educator preparation.
Our primary aim is to determine the depth and breadth of COVID and long COVID education taught in entry-level DPT programs. Our secondary aim is to target educator perceptions, instructional strategies, and whether graduates are prepared to support public health crises. Our methods followed 4 steps. The first step being instrumental adaptation from a valid vestibular survey, expert pilot review, distribution of our survey to program chairs of New York accredited DPT programs, and analysis with the help of a statistician. The 21-item content matrix consists of foundational sciences, examination and systems review, and physical therapy management. The instrument was structured into 5 sections. Each of the 21 items was rated on a 5-level ordinal scale, ranging from essential, not exposed to essential for entry-level education.
I'll talk a little bit about the results. So roughly 78% of the responding programs actually included COVID-19 content in their curriculum. Of those 78%, 70% kept it mostly in the cardiopulmonary course. 86%, it was delivered in year 2. And then about 88% only had 1 to 5 lecture hours. So this is a graphical representation of what I just said. Top graph, again, mostly cardiopulm is where COVID was covered. Kind of makes sense. But you would want to see more interdisciplinary teaching, right? Bottom graph shows, again, 1 to 5 contact hours dominated, but one school did go 11 to 20 hours. Kudos to them. Now, a lot of colors. The one to pay attention to is gray, that's not exposed. There are 3 categories on the left: foundational sciences, which is the pathophys, physiology, anatomy. The second is examination and systems review, so cardiopulm, GI, et cetera. And then how does PT manage COVID and long COVID? So the strongest delivery was in pathology or symptom recognition and pulmonary. And the weakest was actually GI, urogenital, and endocrine, where half the schools were not exposed. And that's odd because even as early as 2022, we know 22% of long COVID patients actually demonstrate GI symptoms.
Just to go further in depth with the results of our survey, these specific results are really important because they highlight a key finding that there is a content essentiality paradox, meaning that programs are actually assessing the content cognitively through like exams and testing. They're also assessing it psychomotorly through practicals, labs, but they are not rating these contents as essential to entry-level practice. So if you look at the little red bars, you see that there's such a small amount compared to the blue bars. So that highlights the difference in what the educators are actually rating as essential versus what they're actually teaching. This is going to signal a drift in the curriculum from the COVID-19 as research is being done, and it's important that we want to address it being as essential in all of these exposure areas. A little bit more in detail relating to the survey items specifically. So across the 3 domains, foundational sciences, examination and systems reviews, and PT management for COVID-19 and long COVID, they have been exposing the content at high rates, so it ranges between 75 to 83%, and there's still the pattern of that paradox continuing where there is a low rate of considering it essential to entry-level practice with responses ranging from 0% to 14%. This is important also because it shows that programs are layering the content without actually reinforcing that these contents need to be essential for entry-level practice, and having students be competent in these skills is important. Some more results from the study. This is more about the survey takers themselves and less about what the students are learning. So this is showing that all of the educators and faculty involved in the study were 100% credentialed and licensed physical therapists. There is a gap in the amount of these people attending conferences. So 60% reported attending a COVID-19 conference or continuing education opportunities for COVID-19. 40% have attended a long COVID conference or continuing education opportunities, which is a huge gap. 50% are actually teaching the content in COVID-19, and then 0% of the faculty are organizing the COVID-19 conferences or symposiums for students or amongst themselves. This big gap tells us that there is a huge risk of the curriculum departuring away from focusing on topics of COVID-19 and actually assessing for competency in students post-grad. And as COVID-19 research evolves, this pattern, specifically in New York State, shows that this is a risk to education that is presented in programs.
Now to touch a little bit more on our conclusion. So throughout our study, we found that COVID-19 and long COVID content is being present in DPT programs at entry level, but it is not deemed as essential as highlighted in our results. So this motivates the need to issue a national curricular collaboration. Now for our strengths, they support that national rollout, but the limitations are bound by their current interpretation. For our study, there wasn't enough data to draw any statistical inference from it and only descriptive inference from it. So that shows what is currently going on right now throughout the programs. Now, the call to action. What needs to happen next? There's 3 things that should naturally follow our pilot study, starting with a national scaling with adequately powered sample. Next, it would follow curricular collaboration with the guidance of organizations like the APTA, World Health Organization, and CDC. Thirdly, faculty development with continuing education infrastructure for long COVID. Now, I'd like to take this time to again thank and acknowledge our faculty mentor, Dr. Puneet Dhaliwal. The statistical support team, the content reviewers, and the DPT programs that participated. Thank you guys for your time, and we'll welcome any questions.
Thank you for that presentation. So you outlined sort of an ambitious next set of steps. What would you think would be a productive route forward? What would be your next goal in this plan?
The next goal is to issue our survey nationally to DPT programs, so we have more of a broad scale so that we can influence that national curricular collaboration that we were talking about.
Thank you.
Thank you.
Wonderful. Let's give them another hand. Okay, so next to the stage, I would like to call the group from occupational therapy. I'll try not to show favoritism, but this group did present this project at our National Occupational Therapy Association conference. So thank you for sharing it today. And you're here. I thought you said you weren't coming. Oh.
Okay, good morning, everyone. My name is Madeline Silverstein.
I'm Madison Tristino.
I'm Elena Scala. And we are excited to present our master's project, Occupational Therapy in Gender Affirming Care, addressing disparities and enhancing participation. So to guide our presentation and research, we developed 3 learning objectives related to serving TGNC, or transgender and gender nonconforming clients. These include identifying current educational and systemic clinical barriers, applying client-centered and inclusive OT interventions, and evaluating clinical practice to see what's being done now and what we need to do moving forward. Existing data demonstrates the need for urgent gender-affirming care. Gender-affirming care consists of interventions that align with and support one's gender identity. This could include reconstructive surgeries, hormonal therapies, mental health care, and so much more. In addition, gender-affirming care also encompasses things like hormonal therapy for women experiencing menopause or men with low testosterone. TGNC patients face higher rates of discrimination in healthcare and have an increased likelihood to avoid care, even in medical emergencies, due to fear or past negative experiences. Research shows that healthcare disparities exist within this population as compared with their cisgender peers who identify with their sex assigned at birth. OTs provide client-centered care that supports all aspects of our client, including their values, beliefs, and interests that make up their identity. This should not and does not change when it comes to serving our TGNC clients. Studies show that healthcare practitioners have low confidence and feel unprepared to work with this population. Our study aims to change that. To begin our research process, we investigated existing evidence regarding affirming OT practice that promotes occupational performance and mental well-being among TGNC individuals. Our literature review of 19 articles provided valuable information to frame our research. Several studies found that there is a need for formal education on gender-affirming practice, including trauma-informed care and gender-affirming treatment. Viewing gender through the gender as occupation framework also helps to support the doing of gender through meaningful occupations like dressing or grooming. Post-operative care is also a critical area for OT intervention, where practitioners can address wound care, mobility, hygiene, and community reintegration. The literature review informed the questions that help to inform our expert consultation process, which is our Delphi study, and Madison will discuss that next.
All right, so now that some background and context for this topic has been provided, I'm going to shift into how we actually conducted our research. Specifically, I'll be going through the methods, including our design, participants, and the data collection process. So our research utilized a modified Delphi approach. This is a systematic, iterative process used to build expert consensus, and it is particularly valuable in emerging or underdeveloped areas where clear guidelines do not yet exist. This method involved anonymous surveys that were distributed across 2 rounds, allowing experts to provide their input, review group feedback, and then refine their responses over time. This is a common method that's used in healthcare research to build consensus on topics. For our research specifically, the goal of using a modified Delphi approach is to generate evidence-based best practice guidelines for delivering care to TGNC individuals via the support of expert consensus. So round one of the survey was distributed across a 10-week period through professional conferences and targeted TGNC and LGBTQ+ allied health email lists. Additionally, recruitment was supported through a flyer that provided study details and invited participation. Participants were also encouraged to share the study with colleagues who met eligibility criteria utilizing a snowball sampling approach. Eligible participants included healthcare professionals and educators with experience or interest in TGNC care. In total, 9 participants completed round one of the survey. And this sample size, although small, does align with other Delphi studies as it is a specialized topic that requires expert input. So as I mentioned previously, this research involves 2 rounds of surveys. And at the current time of this presentation, round one has been completed and analyzed. In round one, participants completed an open-ended survey that was designed to generate expert perspectives on current challenges in TGNC healthcare, the competencies needed to support TGNC individuals, and any gaps in practices that they perceive are currently existing. In round two, participants are invited to review and evaluate statements derived from those round one responses. During this round, participants will rate and rank proposed items based on perceived importance and relevance to different healthcare settings. Once both rounds have been completed and the consensus among topics has been analyzed, the next step would be creating those best practice guidelines supported by said consensus. So moving into our results section, responses from round one of the survey were analyzed using descriptive statistical analysis and qualitative thematic analysis to identify key themes and patterns among participant responses. So the key themes that were identified were education and training, professional development, school-based services, and emerging or non-traditional resources. And to give a quick participant overview, they consisted of 9 licensed and credentialed healthcare professionals, being a mix of occupational therapists and physical therapists. Out of those 9 participants, 66% reported having 5 or more years of experience working with TGNC individuals. Next, Milena is going to break down the results of the survey into those identified key themes.
Okay, so one of the key themes we discovered are that participants are largely self-taught post-graduation and rely heavily on independent learning rather than formal training. Just to introduce you a little further to our panel, when asked to share their perceived level of confidence in their ability to provide affirming care to TGNC individuals, 56% of participants reported feeling very confident. In this chart, you'll see a breakdown of their specific expertise related to TGNC health and issues. So the highest percentage of experience among participants was in community leadership or advocacy involvement, along with having peer-reviewed publications or presentations. Only 1 participant reported having a clinical leadership role or a clinical specialization, while 3 participants reported having none of the listed experience. Despite most participants feeling considerably confident and being experienced in the field, we found that most of their expertise comes from sources of self-education. Of these resources, which you can see here, the most common were peer-reviewed journals, online webinars, professional workshops, and personal narratives or blogs. And smaller percentages of participants reported social media, mentorship, or academic coursework as resources. So as Madison mentioned, the participants' confidence levels and experience support that our panel is appropriate for a Delphi study, but also demonstrate that even among experts, there's potential for greater formal preparation and training. When asked about barriers encountered in accessing education or training related to TGNC care, common themes that emerged include difficulty identifying and finding credible resources, high cost of professional development, repetitive or basic content that's limited to pronoun usage, lack of relevant content in academic coursework, and limited recognition that this is important work. In terms of academic preparation, our study revealed a clear, overwhelming curricular deficit, paired with a strong consensus on the importance of experience-based learning. 89% of participants reported that they felt not at all prepared by their academic programs to work with TG&C individuals. When asked about what specific content was included in their academic training, there was an overwhelming response of none or minimal exposure. Participants also ranked methods of incorporating TG&C content into academic programs, with 1 being most effective and 6 being the least effective. Among the top-ranked methods were guest speakers with lived experience, case studies and clinical placements, followed by simulation or role play, required readings, and interdisciplinary coursework. As far as the actual content our panel feels is lacking in academic training, they expressed a need for exposure to psychosocial implications, hormone and surgical considerations, greater insight into how identity and power shape experiences, post-operative activities of daily living training, such as bathing, toileting, or dressing, and documentation and legal name guidance. Participants emphasized not only the importance of representation, but also how TG&C content is framed within education, noting that it should be fully integrated into coursework rather than in a way that others the population. As one participant wrote, TG&C content is not different or separate coursework. Even beyond academic preparation, there was an apparent need for further training and resources across rehab and school-based settings. Some workplaces offer general LGBTQ+ training or specific TG&C professional development opportunities, while many reported none or insufficient offerings. What participants really wanted was ongoing practical training, with multiple responses sharing the importance of training and resources being continuous rather than standalone content. There was a similar desire for case-based workshops, cultural humility training, post-surgical care guidance, and documentation training in the workplace, as there was with academic curriculum additions. In school settings especially, these gaps showed up alongside other challenges like misgendering, political and legal barriers, and not having clear resources to rely on. Overall, this suggests the problem isn't limited to one field or setting. It's a broader issue with not enough consistent, relevant training or institutional support across disciplines.
So in summation, the overall trends that were revealed included the following. Participants reported relying heavily on self-directed learning due to limited formal education on TG&C care. Most participants felt unprepared by their academic programs with little to no exposure to TG&C related content. Key gaps in education included a lack of foundational knowledge, limited intersectionality training, and an over-reliance on binary frameworks. Overall, participants emphasized the need for a more inclusive and comprehensive curriculum, including diverse identities and experiences. So our group did identify some study limitations, which included the sample size, as it was smaller than initially intended, partly due to some recruitment challenges and limited visibility at one conference. Additionally, there is a lack of existing literature on this topic, which made it difficult to fully guide the survey development. The findings are also based on self-reported data, which can introduce some bias. Another limitation is the lack of interdisciplinary diversity among participants, which affects how broadly the results can be applied. Lastly, and most importantly, the study did not include direct perspectives and input from TG&C individuals, which means that lived experiences were not and could not be fully represented in this research.
Our data confirms the need for healthcare practitioner education to ensure confidence and readiness to work with TG&C clients and to promote cultural humility and carryover to clinical practice. So what can we do? The value of learning from lived experience to provide quality care for TG&C clients was highlighted throughout our research, making building relationships with TG&C individuals and experts in the field especially important. Healthcare practitioners must also remember and educate their students that TG&C care is medically necessary care. Our commitment to ethical practice as providers does not discriminate. We prioritize important identities and for SOTs, occupations for all of our clients. In the professional world, capstone partnerships and interdisciplinary professional development programs can be implemented to support continuing education in this topic, tailored to the needs of the specific treatment setting. Within the academic arena, professors and administrators should consider curricular updates and inviting external trainers with lived experience to share their expertise with faculty and students. Systemic challenges and institutional policy changes in the current political climate also affect the delivery of TG-NC care and minimize the importance of professional development and readiness for this population. Continued and consistent advocacy can ultimately create systemic change institutionally and in education for TG-NC clients seeking healthcare. Advocacy is central to equitable, accessible, and comprehensive TG-NC care. Thank you, and here's our mentor, Dr. Rappaport. So thank you for her support throughout the project, and here are references. Thank you.
Hi, thank you so much for this important presentation. I don't really have a question, but more of a comment, and I think at the end, in your summary, you kind of leaned into it a little bit, which is that it's an area that all of us who are providing care for people in the community need to know more about and hold and advocate for folks, and that especially because of the political climate and the extraordinarily brazen oppression that's going on, that we all dabble in mental health in our professions, but we have to also remember that, that our support might involve those kinds of referrals. Thank you.
Yeah, how would you deal with, okay, so yeah, how would you deal with or handle, like, I would say client clashes? Like, let's say that, you know, clients, they want to feel safe and they want to feel included, everyone does, but the TNGC community may make them feel unsafe. And also, like, how do you bridge the gap between respecting other people's beliefs that they already have and supporting TNGC in those spaces?
Okay, that's a good question. We have talked about ways to support and respect TG-NC clients, even in little ways in the workplace. Little things like wearing a pin and just demonstrating that you're a safe space, asking for pronouns, and making it kind of like across the board for all of our clients. But as healthcare providers, it's our duty to serve everyone. So I think despite, you know, what your own stance is, it's part of our work and it's ethical. And I think clients can sense, you know, if you really are a safe space or not, and to make an effort to portray that in your work.
I would just add that I think if it is something that you disagree with or feel uncomfortable with, I think being curious about that is important as well, because we really are just looking out for the best interests of our clients, and I think if it's something you're uncomfortable with, like those things can show up in different ways when you're providing care, and those things may be something you're not thinking about, but it can still make whoever you're working with feel uncomfortable in whatever way, so.
Okay, we are making incredible time. Just a quick reminder for those who joined us a little later, there's a QR code right behind me for you to scan so that we can mark attendance. We want to make sure we have everyone who's here represented. And now we will go on with the recognition of exemplary student projects. I want to give thanks to Dr. Yasser Salem, Dr. David Kaufman, Dr. Irina Struck, Dr. Vanessa Valles-Lewis, and all the poster judges. We wanted to make sure that we recognize and honor the incredible student work that's happening. So we have certificates for those groups who scored the highest. If your group is called, I invite you to the stage to pick up your certificate. So first, the project title is Effect of Motivational Interviewing on Pain Self-Efficacy in Chronic Musculoskeletal Pain, a Systematic Review. The project advisor is Dr. Dawn Tribble from the Occupational Therapy Program. And the students are Jenny Kim, Sharon Park, and Noah Polakos. Please come to the stage. Next, the project is titled Development of a Self-Directed Learning Module for the Knee MSK Ultrasound for DMI students. The project advisor is Professor Irina Struck. I invite to the stage Charmaine Joseph, Yasmin Serrano, and Jonah Portzilla. The next project we want to recognize comes from the Health Informatics Program. The project title is Digital Health Inequities in Telehealth, Broadband Access, Socioeconomic Disadvantages, and Community-Level Disparities in Virtual Care Utilization. The project advisors are Dr. Mohammed Fessa and Dr. David Kaufman. I invite to the stage the students, Armand Chaudhry and Yu Shandeng. Welcome. Would you like to take it? No. I have a few more. Okay. There might be more. Okay. Next to the stage, the project title is Predictive Modeling and Acceptability of a 24-hour RBC transfusion risk calculator in ICU patients with upper gastrointestinal bleeding. This is also from the Health Informatics program, so glad you didn't go too far. Dr. Kaufman, Dr. Faso, I invite to the stage students Christina Cho, Eric Gaitan Baraclado, and Shuyi Lee. Congratulations. Okay, 2 more projects. This next one is titled Social Determinants of Health and Fall Risk in Older Adults, Implications for OT Practice. The project advisor is Dr. Tanya Taylor, Marco Stilo, Siham Benes, and myself. I invite to the stage the students Jenica Fivos, Lugina Guasco, and Geneva Almonds. And lastly, this was the highest ranked project as voted by the faculty. The project title is Protecting Sonographers' Hand Health, an evaluation of carpal tunnel signs and ergonomic factors. The project advisor is Douglas Dunsatter, and students I invite to the stage Jade Medina, Tasneem Salah, and Leandra Ogilvie. All right, congratulations to each of the recognized groups. I invite everyone to check out their posters in the atrium. We are making incredible time. So right now we will break. We'll break for poster viewing. So at this point, everyone who has a poster, stand by your posters. People will come up to you, engage with you, ask you questions. We'll do that for a little bit, then we'll open up the room. We have bagged lunches. And then we will return back here for the final presentations at 1 p.m. Thank you.
wait a bit?
Yeah. Yeah. Oh.
See if we can get our folks.
Mm-hmm.
So our team is second, right?
Mm-hmm. Yeah, we'll go DMS.
There's only the two left plus the awards.
Well, we did the awards.
You did the awards.
We did. We did.
So people listen. It's the same thing.
Okay, thank you, everyone. Welcome back. If you can, we'll give everyone a few minutes to come back. It's a beautiful day outside. If you are in touch with them, let them know we're going to begin shortly. So let's give everyone about maybe 5 or 10 minutes, okay? Okay, we're going to get started in another 2 minutes. Just allow everyone who was here this morning to trickle back in. If you missed the announcements this morning, there is a QR code on the screen for you to capture, and you can log your attendance. It's important for us to make sure everyone is here and that we recognize that. The next group that we will have to the stage is from the Diagnostic Medical Sonography Program. I'll call you to the stage in 1 minute. And again, if you are in touch with your classmates, your peers, just remind them we're going to get started. All right, welcome back to SOHP Research Day. I hope you had a great break where you were able to go out into the atrium and check out the posters from your classmates, as well as from some of the other programs, and connect and ask questions. We're back with the second half of our program, and to keep us going, to keep the momentum going, I want you to give a big round of applause, a big welcome to the DMS program, Diagnostic Medical Sonography. Come to the stage.
All right, hello everyone. Hi, my name is Lynette Pius, and I am here with my co-presenters, Shantae, Mayor, and Kayleen. Before we begin our presentation, we would like to give an acknowledgement to our principal investigator, Professor Yan Lu Lee, who greatly helped us in our research. Okay, so our presentation is on peer-to-peer renal POCUS training, sonography students teaching physician assistant students. All right, oh, where's the, okay. All right, so starting with POCUS in clinical setting. So what is point of care ultrasound, or also known as POCUS. So it is a bedside tool used by healthcare providers, including physician assistants, to quickly assess patients with the use of ultrasound. It allows for real-time imaging, which helps providers make faster decisions about diagnosis and treatment. Unlike traditional ultrasound exams where we use protocols and other types of procedures, POCUS is usually focused on answering specific clinical questions rather than doing a full comprehensive study. It is also very accessible because it uses handheld or portable machines, like the picture shown below. Show it right there. And it is very good for the emergency room. All right, moving on into educational gap in PA programs. All right, so one of the main issues is that many PA programs do not include formal or structured ultrasound education in their curriculum. So because of this, students often have limited exposure to sonographic imaging and may not fully understand how the ultrasound machines work. So this inconsistency in training can sometimes lead to overconfidence or misinterpretation of images, impacting patient care. So overall, there is a clear need for effective, structured, and accessible ways to teach ultrasound skills to PA students. Moving on to peer-to-peer teaching and healthcare education. So to address this gap, peer-to-peer teaching can be used as an educational solution. This approach involves students in a shared learning environment. Research shows that peer teaching can improve engagement, boost confidence, and help with long-term knowledge retention. So for this reason, sonography students make the perfect candidate to teach these skills, since they already have specialized knowledge and hands-on experience. However, this type of peer-led instruction is still underutilized in many PA program education, even though it has strong potential. And then lastly, we have significance of renal ultrasound and the connection to POCUS and PA programs. So renal ultrasound is especially important because the kidneys are commonly evaluated in emergency and primary care settings. Being able to quickly identify normal, as we have shown right here, normal kidney versus abnormal findings like hydronephrosis, kidney stones, and other ones that we have listed below, like cortical cyst, chronic kidney disease. It is very good. So accurate interpretation helps reduce unnecessary repeated exams and improves efficiency in patient care. So overall, improving training in renal ultrasound can increase provider confidence, improve diagnostic accuracy, and lead to better patient outcomes.
So to understand whether or not ultrasound students can effectively teach PA students, we looked at research on peer-to-peer teaching and ultrasound education. These studies helped show how student teaching works compared to traditional instruction. So one of the key studies that we looked at compared near-peer teaching, which were senior students or residents, to faculty teaching in point-of-care ultrasound. There was about 73 third-year medical students, which completed a pre-test, post-test, and a hands-on clinical exam. What was important here was that both groups improved significantly after their training. However, there were no meaningful differences between the groups in terms of their knowledge, their hands-on skills, or even how confident the students felt after. Overall, the study showed that near-peer teaching can be just as effective as faculty-led teaching, which supports the idea that students can successfully teach other students. Building on that, we also looked at how ultrasound can be introduced into programs that don't have traditionally strong ultrasound training. This study focused on adding POCUS into a PA program's curriculum, And here, after just 13 hours of their training, the students achieved super high levels of accuracy with a 97% in image acquisition and an 85% in understanding how to apply it clinically. They also had super positive attitudes towards ultrasound, with 90% of the students agreeing that it was an important skill. This just goes to show that with limited time, students can learn quickly and apply their ultrasound skills effectively. And it's especially relevant to our study because it supports the idea that PA students are capable of learning ultrasound in a relatively short and structured session. Beyond faculty-led teaching, there was also research looking at students teaching other students. So this study in specific looked at student-led ultrasound curriculum in a medical school where the students were in charge of teaching one another. The timeline here shows that the breakdown, how the breakdown of the curriculum was structured. So in the beginning, the students were completing pre-assessments to evaluate their baseline knowledge. And then throughout a number of days, they were given instructional videos and attended lectures to build their foundational knowledge. Then they participated in a hands-on practice session with their instructors, which is where they developed their scanning skills. And then finally, they completed post-assessments to measure their improvement. Overall, this structured approach combines independent learning, guided instruction, and hands-on practice, which is very similar to how our study was designed. And the study supports that student-led teaching, when structured properly, can be an effective way to learn ultrasound. And with that, we have our research question. Can a brief POCUS-focused teaching session led by sonography students improve PA students' ability to identify normal and abnormal kidney findings on ultrasound images?
So for our materials and methods, we reached out to the PA program. 7 of them expressed interest in doing this research with us. We handed pre-surveys to just assess baseline knowledge about what they know about kidneys and how to just use the machine. And then afterwards, we also gave a post-survey to just same questions to just see how effective the lecture and the hands-on scanning was. For the lecture portion, we just covered basic renal anatomy, normal. We covered some common pathologies seen in the ER, such as renal cysts, some kidney stones, hydronephrosis, and then just normal image orientations, how to use the machines. We then did a hands-on session and practice. So we basically, first I used one of my classmates as a demo. I did a basic kidney scan, showing them how to use the machine, and then they broke up into 4 different groups, each of us going with the group, and we just supervised as they basically scanned. This took place in our DMI classroom in our lab, and these were the machines that were used.
All right, so we're going to talk about results over these next several slides. So you may look at this slide and just say, okay, cool, like what previous ultrasound exposure have you had? We actually kicked off our pre and post surveys with this question because we wanted to know, right? Maybe our understanding of their exposure to ultrasound scanning was incorrect. So if you look here, a lot of them have had exposure as a patient, a family member, maybe they observed it in their clinical settings. But what's really stands out to me is where you don't see any data listed at all about I have personally operated or used an ultrasound machine. Well, this supports our research very directly in us thinking that there needs to be more support in a PA program for them to have this exposure because they are expected to know how to use an ultrasound machine, albeit a POCUS machine, in a clinical setting. So one of the other questions we wanted them to, wanted to see like, hey, maybe you haven't had exposure to an ultrasound machine and you haven't actually operated it, but maybe you can actually identify images on an actual scan. So we said, hey, can you identify normal kidney anatomy on ultrasound image? If you look here, 86% of our participants were not confident at all. However, after after our classroom teaching lesson, as well as our scanning session, there is a complete different result where we now have no not confidence, but we have everybody that is expressing some type of level of confidence. We also asked them about renal pathology. So we showed them this image and we said, hey, what do you guys think this is? We have a little mixed bag of, and I'm laughing because I'm looking at some of our participants now. But we have a little mixed bag of responses here. So we had, kidney stone. People thought it was a normal kidney. Hydronephrosis, which is actually what that image is. But the point of showing this is that after our lessons, you can see now that the majority of our participants were completely more confident in actually recognizing the pathology. We also asked them about differing, or how to use different technologies such as focus, TGCs, or gain, which are some of the very basic functions that you need to operate and optimize your image effectively on an ultrasound machine. So we asked them, do you know how to adjust gain and TGC on an ultrasound machine? So you're like, well, where are my other slices? I mean, this is a yes or no answer. No, nobody even knew what that was. However, after Mayar's great teaching and we went into the lab, you can now see that the majority of our participants were very confident in being able to at least operate the bare minimum in order to optimize their image effectively while scanning. So we also asked about some open-ended feedback. We were like, okay, so this is fun. We've enjoyed our time together, but did you actually find it relevant? Did you get anything out of the sessions? So these are direct quotes that we received. It was very beneficial. I enjoyed learning and practicing on others and being able to visualize the spleen, kidneys, and liver. And it is definitely important to learn and understand as a future provider. Very beneficial, great content. It was really helpful a lot. I learned a lot about ultrasound and pathologies, and I think the content is the perfect amount for students with small knowledge of ultrasound. And this lab was very informative. I liked how you guys gave a presentation about the organ beforehand and how you guys have a rundown. It was very nice to see how to properly view images, and would love to get a chance to see other structures and more sessions like this in the future. This was great. So, this is all great feedback for us. We're like, yeah, like this really, worked out the way that we hoped that it would. But in the end, we also wanted to know, do you think that this is relevant and beneficial for you as a future PA practicing, clinician? And there was a resounding, absolutely yes. So how relevant do you believe POCUS skills are to your future role as a PA? And unequivocally, 100% agreed that it is.
Okay, as for our results, after we collected pre and post surveys with 17 questions, they were the same questions before and after. We found that overall there was increased accuracy when it came to identifying renal pathology. There was also much more confidence when it came to using the ultrasound machine by the end of the session. And most of them chose, if not all, found great interest when it came to learning, and found that the time that they spent with us was useful. So some limitations for our research was that we weren't guaranteed any participants until the day of. We did have a small sample size of 7 people. The instructions did have to be followed correctly on the pre and post survey, and the data had to also be recorded accurately. And also missing or incomplete data can occur. So in terms of future direction, we had the midwifery program reach out to Professor Lee to express interest in incorporating peer-to-peer collaboration in the future. This was after they learned about the successful collaboration we had with the PA students, where it helped them understand clinically and technical skills along with teamwork. So this is expected to expand in the future into joint simulation labs, which we have upstairs for OB, and then clinical scenarios where the midwifery students can practice some like OB emergencies and routine assessments in real time. So to conclude, overall peer-to-peer was successful. It helped improve their knowledge on kidney anatomy, normal and abnormal. It also was very accurate when it came to identifying renal pathologies, as I mentioned. And the students really valued the hands-on peer-led approach. This model can be adapted to other programs in the future to enhance skills, teamwork, and clinical learning. I would like to thank all the PA students that made this research possible. Really appreciate it. And that is it.
Thank you.
Any questions? Thank you.
Maybe just a suggestion. I think the nurses would also be very interested in collaborating with you guys, just because the ultrasound is kind of our last resort as putting in an IV or getting any sort of blood or an A-line. So all of those things, like, they would jump at the chance to be able to work with you guys.
Great, thank you. Thank you.
Wonderful, thank you, thank you. That was an excellent example of interprofessional practice and education. Great job. So for our next and last group, we have Health Informatics coming to the stage. Welcome.
Good afternoon, everyone. My name is Erica, and today, along with my team members, Christina and Shuhei, we will be presenting our research project on predictive modeling and acceptability of a 24-hour red blood cell transfusion risk calculator in intensive care unit patients with upper gastrointestinal bleeding. Upper GI bleed is a life-threatening medical condition that's associated with increased mortality rates in the ICU. When managing upper GI bleeds, there's a few clinical considerations that are important to take into account. First, these patients in the ICU often have rapid physiologic changes, so their status can change or deteriorate quickly. At the same time, they can also have atypical presentations, especially when critically ill or sedated. As a result, the management of upper GI bleeds in the ICU is a complex and multidisciplinary task requiring continuous assessment and intervention. In terms of clinical guidance, the gold standard used for managing upper GI bleeds is based on the American College of Gastroenterology. Risk stratification tools like the Glasgow-Blatchford score helps guide clinical decisions involving upper GI bleeds. It's known to help with early patient triage and to identify whether a patient is more likely to need an intervention. The transfusion strategy commonly recommended for upper GI bleed patients who require a transfusion is to follow a restrictive transfusion approach, where transfusions are administered when hemoglobin levels drop below the level of 7 grams per deciliter, or if there's other clinical concerns like ongoing hemodynamic instability, active bleed, or a rapid drop in hemoglobin. In general, 1 unit of PRBCs increases the hemoglobin by 1 gram per deciliter, which is why units are often given in 1 to 2 unit increment followed by reassessment. Beyond clinical decisions, it's important to recognize that RBC transfusions have an impact on healthcare resources and costs. Even though PRBCs are life-saving, they're expensive and they're also limited in supply. In the US alone, more than 14 million units of packed red blood cells are transfused annually with an acquisition cost of over $250 per unit. But when you factor in storage, testing, and administration, the overall hospital cost can exceed $700 per unit. And on top of that, approximately 10% of these transfusions may be unnecessary. RBC supply is also a scarce resource. We're still experiencing a 10 to 12% shortage post-COVID, and availability ultimately depends on blood donors. While transfusions are critical, the question that arises is whether our current tools help us make these decisions more effectively. Given the complexity of managing upper GI bleeds in the ICU, clinicians often rely on existing risk stratification tools. And while risk stratification tools are important and helpful, they do have key limitations, especially in ICU. The Glasgow-Blatchford score is one of the most commonly used tools for risk stratification for upper GI bleeds. It's mainly designed to aid in the identification for interventions, assess bleed severity, and predict mortality rates. What it doesn't actually do is estimate the probability that a patient might need a blood transfusion, which is a key gap in upper GI bleed management. And it also offers a limited guidance for real-time decision-making. Also, these tools were developed using data from non-ICU populations, so they may not fully capture the complexity and physiologic variability seen in critically ill patients. There are also practical limitations, such as the need for manual calculation, and they lack the integration into clinical workflows, which can limit the use in real-time sensitive settings. To address these gaps and limitations, our study had two main objectives. First, to develop a risk calculator that predicts 24-hour RBC transfusion probabilities for ICU patients with upper GI bleeds, and second, to evaluate the tool's usability and acceptability among healthcare providers, professionals, and administrators. Our goal with these objectives was not just to build a predictive model, but to also create something that could be clinically useful and practical. For the study, we used a mixed methods design, combining both a quantitative component and a qualitative component to provide a more comprehensive evaluation of the risk calculator in real-world clinical settings. For the quantitative portion, we use a retrospective data analysis from the MIMIC4 database. We specifically used the version 2.2. We extracted this data using SQL, and then we processed and developed our model using Python, where the final output shows a 24-hour transfusion probability. We also conducted a qualitative analysis involving semi-structured interviews with healthcare professionals and administrators with a total of 10 participants. The goal here was to assess the tool's usability and acceptability. Now moving on to the model development. Starting with the modeling approach, we performed a logistic regression and developed the model in Python using skitlearn. For predictor selection, variables were chosen based on clinical relevance and prior literature review. These included both lab and physiologic parameters. The lab variables chosen were hemoglobin, BUN, which stands for blood urea nitrogen, and BUN to creatinine ratio. Studies have shown that BUN creatinine ratio have an indirect association with upper GI bleed severity. Given the trajectory of the blood traveling down the GI tract, proteins from the blood get digested and further metabolized into urea, increasing BUN levels. Severe upper GI bleeds can also cause hypervolemia, which is characterized by low blood volumes, and can cause renal perfusion, which causes the increase in BUN to creatinine ratio. The physiologic variables chosen were systolic blood pressure, mean arterial pressure, and heart rate, as they reflect the patient's hemodynamic response to bleeding. In terms of data processing and validation, missing data was handled using median imputation. The data set was processed using a test-train split, where 70% of the data was used for training and 30% of the data was used for testing. Lastly, we performed a 5-fold cross-validation to assess the model's performance, meaning that the model was trained and tested multiple times on different subsets of the data to ensure consistent performance.
After developing the model, we evaluated its performances using several metrics, including the discrimination, calibration, and the Briver score. So shown on the right side we have the receiver operating characteristic or ROC curve showing a area under the curve of a 0.89, indicating the model's strong ability to differentiate between patients who do and do not require transfusion. And shown on the left side is the calibration curve, showing a mixed deviations from the perfect calibration line, which suggests some overestimation of the transfusion risk from the low to mid probability ranges. This may be due to a class imbalance and overfitting during the model development process. However, the low Briver score of 0.14 showed a good probabilistic accuracy of the model's overall performance. So overall, the model demonstrated a good discrimination and a good overall probabilistic accuracy despite some of the calibration limitations in specific ranges. We also evaluated the model's classification performances at, based on a selected threshold of 0.40. So the contagious table shown on the right side shows that the predicted classifications with the observed outcome and was used to calibrate the performance matrix. And so at this selected threshold of 0.40, the model achieved a high sensitivity of 92%, indicating that the model correctly identified most patients who required a transfusion. Specificity was 61%, indicating that a higher rate of false positive, which means that some patients were incorrectly identified as requiring transfusion. The lower specificity reflects the trade-off leading to maintain a high sensitivity, but clinically, this trade-off might be acceptable since prioritizing sensitivity helps minimize false negatives and reduce the risk of missing patients who need transfusion. This is important because missing a patient who requires transfusion might have more serious consequences than over-identifying some patients who do not. Overall, the model showed a high sensitivity, which may support early identification of upper GI bleed patients that are at risk of transfusion. Following classification performances, we identified the key predictors of RBC transfusion using logistic analysis. The analysis showed that the hemoglobin was a significant predictor of RBC transfusion. Lower hemoglobin level is strongly associated with an increased likelihood of transfusion risk, which may reflect severe blood loss and or anemia. Heart rate was statistically significant. A predictor with a higher value is associated with increased transfusion risk, but small effect size, which might reflect an influence of the sample size. And the BUN to creatinine ratio showed a possible trend toward an association with increased transfusion risk, but was not statistically significant. Finally, we compared it with the GBS tool, which has a broad use, a clinical use, and incorporates with multiple clinical variables to assess patient risk, and has a strong discriminatory ability with an area under the curve of approximately 0.89. Our risk calculator was designed specifically to predict transfusion in upper GI bleed patients and achieved a comparable level of performances with also an area under the curve of 0.89. But our model used fewer clinical relevant variables with a focus on only those that are most clinical relevant. This may support easier clinical interpretations, which suggests that simpler and targeted models may be sufficient in time-sensitive settings.
For the qualitative portion of the study, we used the Technology Acceptance Model, or TAM framework, to guide our analysis of participant perspectives towards the transfusion risk calculator. We identified several predefined themes, including usability, trust, workflow integration, and barriers to adoption, and we also included a baseline perspective theme to better understand clinicians and other professionals' existing approaches to decision support tools within their work environment. In addition, an emergent theme related to clinical and system-level applications developed from participant responses during analysis. And overall, usability, trust, and workflow integration appear to strongly influence the acceptability of the tool, which in turn impacts the likelihood of adoption and real-world clinical use. We first explored baseline clinical practices and perspectives related to transfusion decision-making in patients with upper GI bleeds. Participants generally describe transfusion practices as relatively standardized, most commonly guided by the hemoglobin thresholds, particularly a hemoglobin level below 7, in combo with clinical factors such as symptoms and evidence of active bleeding. In terms of attitude toward clinical decision support tools, clinicians and other healthcare professionals were generally familiar with and receptive to these technologies, while administrative and lab staff reported more limited direct exposure within their specific roles. Overall, participants viewed the tool as supportive aids rather than replacements for clinical judgment. The participants also emphasized that decision support tools may be most valuable on more uncertain or borderline clinical situations where the decision-making is less straightforward. And as reflected in the quote, one participant described bleeding management as a clinical gray area where decision support tools could help support decision-making. For usability, participants generally found the tool to be clear, intuitive, and easy to use. The interface was described as simple and straightforward, with visual elements such as color coding helping improve interpretability and ease of navigation. Participants also appreciated the ability to generate a quantified estimate of transfusion risk, particularly as a way to provide additional clinical context during decision-making. However, perceptions of usefulness varied among participants, and some viewed the calculator as a valuable adjunct to clinical assessment, while others felt it was less useful for directly guiding transfusion decisions in certain situations. But overall, usability was considered a strength of the tool, although its perceived practical value depended on the specific clinical context. Overall, participants reported moderate levels of trust in the calculator, generally ranging from about 5 to 8 out of 10, with 10 being the highest level of trust. However, this trust was highly conditional, meaning participants emphasized that trust depended on several key factors, particularly transparency, understanding how the model generated the predictions, and the need for real-world validation. There was a strong preference for clear and interpretable outputs, with many participants expressing hesitation toward black box models where the reasoning behind the predictions is unclear. Participants also noted that the calculator may not fully capture patient-specific context or the complexity of real-time clinical situations, especially in high acuity settings like the ICU, where clinicians rely more heavily on their own judgment and experience. But overall, these findings suggest that trust depends on transparency, validation, and alignment with their existing clinical practice. Participants consistently emphasized that workflow integration is critical for successful adoption of the risk calculator. There was a strong preference for integrating the tool directly into the electronic medical records, such as Epic, rather than using it as a separate standalone calculator. Automation was also identified as an important factor. Participants expressed the need for automatic extraction of the lab values and vital signs directly from the patient chart in order to reduce manual data entry and minimize time burden. The participants also emphasized that the tool would need to fit seamlessly into their existing clinical workflows and remain quick and easy to access. In addition, interoperability between the systems, including the EMR and laboratory information systems, was viewed as an important for supporting coordination across the care settings. But overall, participants felt that adoption would depend heavily on how well the tool integrates into existing clinical workflows. But even with strong workflow integration, the participants identified several barriers that could limit adoption. First, the participants raised concerns regarding model-related limitations, including limited representation of patient-specific factors and questions about generalizability across the different patient populations. Challenges related to interpretability and actionability were also identified, particularly uncertainty around how predicted probability should be incorporated into clinical decision-making. The data limitations were another important concern, including reliance on only static inputs and the limited ability to capture dynamic clinical changes over time. Participants also noted that manual data entry could increase workflow burden and introduce potential for input error or inconsistency regarding which clinical values should be used. Finally, workflow constraints, especially limited time in high acuity settings and the need to avoid additional clinical steps, were viewed as barriers to consistent use. As reflected in the quote, some participants expressed uncertainty about how to act on the model output in practice. I don't know what to do with the probability of this transfusion. Overall, these findings highlight key implementation challenges that would need to be addressed to support successful real-world adoption. And finally, we explored potential clinical and system-level applications of the risk calculator. From a clinical decision support perspective, participants felt that the tool would be most useful in moderate risk scenarios. For example, when a patient has a hemoglobin of 6 with unstable vital signs, the need for a transfusion is usually clear. And similarly, if a hemoglobin is 13 and patient is stable, transfusion is unlikely to be necessary. Participants felt that the calculator may be most valuable where clinical decisions are less obvious. The participants also noted potential value for proactive patient monitoring by helping identify patients who may require closer observation or follow-up. And at the systems level, the participants highlighted potential applications in resource allocation and blood product management, as well as opportunities to support quality improvement initiatives. And as reflected in the quote in the screen, several participants felt that the tool could be particularly helpful in situations where clinicians are on the fence regarding management decisions. And overall, these findings suggest that the risk calculator may have value not only for individual clinical decision-making, but also for improving broader system-level efficiency. Alongside these potential applications, we also identified several important strengths and limitations of the study. A major strength of this study was the integration of quantitative model development with the qualitative end user perspectives. It allowed us to evaluate not only the model performance, but also the real-world factors that may influence adoption and implementation. However, several limitations should be considered. First, this was a single-center data set, MIMIC4, which may limit generalizability to other patient population and healthcare settings. Secondly, for the qualitative sample size, it was relatively small with only 10 participants. In addition, we did not perform a formal probability calibration and external validation, which will be important before a broader implementation. Importantly, we were also unable to interview any nursing professionals, which is important since they are the first point of patient contact and they have such a critical role in these ICU workflows. These limitations highlight important opportunities for future work. So the future work includes external validation across the diverse patient populations and clinical settings, as well as prospective evaluation of clinical impact. And there's also an opportunity to enhance the model by incorporating dynamic clinical data and additional patient-specific context. Integration into the EMR systems and development of a more actionable output may further improve usability and workflow integration. And finally, including nursing perspectives and other frontline stakeholders will be very important for real-world implementation. So in conclusion, we developed a predictive model for red blood cell transfusion in ICU patients with upper GI bleeds that demonstrated performance comparable to existing tools while using fewer clinically relevant variables. Our findings suggest that the model may be most useful in uncertain or moderate risk clinical scenarios where transfusion decisions are less straightforward. Importantly, the tool is intended to support clinical decision-making and not replace any clinical judgment. Importantly, our qualitative findings showed that strong predictive performance alone is not sufficient for adoption, and that successful implementation also depends on usability, trust, and workflow integration. The participants emphasized the importance of tools that are accurate, actionable, transparent, and seamlessly integrated into clinical workflows. By supporting decision-making in uncertain scenarios, tools like this may also help improve patient care, resource utilization, and more efficient and appropriate use of blood products, particularly in settings with increasing resource constraints. Ultimately, our findings suggest that the value of predictive models lies not only in their accuracy, how correct they are, but also how effectively they integrate into the real-world clinical practice. Thank you so much for listening, and before we wrap up, we would also like to give a special thanks to our professors, Dr. Kaufman, Dr. Faisal, and Dr. Liu, for their guidance, mentorship, and their support throughout this project. Thank you so much.
We have a little bit. Comments, thoughts, parting words?
Yeah, I more have comments. This was a really good presentation because it was very thorough. My question originally was going to be, how do you guys see it being integrated within the hospital setting? But you covered that already, so really good job.
Thank you. Thank you.
You want to come on stage? All right, well, that brings us to the end of our day today. Thank you, everyone, for your participation, for the work that you've done over the semesters to showcase everything that you're doing in terms of advancing your practice and education in your respective fields. And also even just taking out the time this week. I know it's a finals week, it's commencement and convocation for a lot of you. But there was really good energy today, and I'm very happy that we all able to come together as a school. Again, just want to give thanks to the different programs, to Dr. David Kaufman. Let's give him a hand. And Dr. Yasser Salam in the back. And the rest of the SOHP Research Day Committee for organizing this day. Again, my name is Effie Conan Newware. I'm the chair of the OT program, and thank you. Have a good afternoon.